Hey everyone, and welcome to this explainer. Today, we're diving straight into the complex, highly structured, and honestly, kind of fascinating world of ICD-10-CM guidelines. We're going to be specifically focusing on hypertensive chronic kidney disease and cardiorenal disease. If you spend your days staring at patient charts trying to untangle multiple chronic conditions into a clean, compliant string of alphanumeric codes, well, you're absolutely in the right place. We're going to break this all down visually to make sure you have complete confidence every single time you encounter these categories. So let's get into it.
Okay, here's our quick agenda for today. 1. Hypertensive chronic kidney disease. 2. Coding the I-12 category. 3. The cardiorenal connection. 4. Navigating those I-13 combination codes. And 5. A clinical case walkthrough to tie it all together.
All right, let's kick things off with Section 1, Hypertensive Chronic Kidney Disease, the foundation.
So, the absolute most crucial point to grasp here is the WITH guideline. In the coding world, when hypertension and chronic kidney disease, or CKD, coexist in a patient's chart, you don't actually need the provider to explicitly write CKD due to hypertension. The ICD-10 coding guidelines automatically assume a direct cause and effect relationship. They are presumed linked. You treat them as a single combined condition for your primary code. It's a massive time saver, but you've got to know to look for it.
But hey, every good rule has an exception, right? You should treat this explicit exception rule like a giant yield sign. You must pause and verify your provider documentation. Why? Well, because if the provider explicitly states that the CKD is due to a completely different underlying condition, like diabetes, for example, that assumed link between the hypertension and the kidney disease completely breaks down. If it's diabetic CKD, you step away from those hypertensive kidney codes entirely.
Moving right along to Section 2, coding the I-12 category and visualizing the splits.
Now that we understand the assumed link, let's look at how the manual actually categorizes these. The entire I-12 category branches neatly into two distinct pathways, based entirely on the severity of the kidney disease. I-12.9 is your go-to code for the early stages, so that's stages 1 through 4, or if the stage of the CKD is just left unspecified. But stepping up the severity, I-12.0 is reserved strictly for stage 5 CKD or end-stage renal disease, known as ESRD. It's a simple, binary split right at that stage 4 to stage 5 threshold.
But hold on, you're not done just by picking I-12.9 or I-12.0. Remember, an I-12 combination code alone just isn't enough. You absolutely must follow it up with mandatory secondary codes. You always need a code from the N18 category to paint the full clinical picture of the precise kidney disease stage. Whether that's N18.1 for stage 1 or N18.6 for end-stage renal disease, you need it there. Furthermore, if your patient has ESRD and the documentation mentions they require chronic dialysis, the guidelines explicitly state you've got to also assign Z99.2 for dependence on renal dialysis. This is what creates a complete, fully compliant coding sequence.
Okay, on to Section 3, the cardiorenal connection, exploring the three-way link.
Now, what happens when a patient presents with hypertension, heart disease, and chronic kidney disease all in a single encounter? Well, we are no longer in that two-way I-12 territory. The guidelines dictate that you've got to combine all three into a single classification. We upgrade from the I-12 codes to the I-13 category, hypertensive, heart, and chronic kidney disease. It's like upgrading your lens to see the whole systemic picture.
Which brings us nicely to Section 4, navigating I-13 combination codes, the 4 key codes.
When those three conditions intersect, we unlock the I-13 category, and it really just boils down to 4 distinct combination codes. It becomes beautifully logical once you ask yourself 2 simple questions. First, is heart failure present? And second, how severe is the CKD? If there's heart failure and mild to moderate CKD, boom, you land on I-13.0. If there's no heart failure, but mild to moderate CKD, it's I-13.10. Now, if the CKD hits stage 5 or ESRD, but there's still no heart failure, you use I-13.11. And finally, the most severe combination, both heart failure and stage 5 or ESRD, brings you straight to I-13.2. It's basically a perfect matrix.
Just like we saw with the two-way codes, your I-13 combination code acts as the anchor, but it's never the whole story. You absolutely must add mandatory secondary codes here too. If your I-13 code indicates heart failure is present, you must assign an additional code from the I-50 category to identify the specific type of heart failure.
And you must always assign an N18 code to identify the precise stage of the chronic kidney disease. Without these secondary codes, your claim is just lacking the specificity the guidelines demand.
Let's put this into practice. Section 5, Clinical Case Walkthrough.
Imagine you're reviewing a chart for a 74-year-old patient. The provider has documented 3 specific things: hypertension, chronic systolic heart failure, and CKD stage 5. Based on everything we've just covered today, what is our exact sequence of alphanumeric codes? Take a second to think about our grid and our secondary code requirements.
All right, let's break this down step by step together. Step 1, we've got hypertension, heart failure, and CKD. That's a 3-way link, so we know for sure we're in I-13 territory. Because there is heart failure and the CKD is severe, we're talking stage 5 here, we grab our I-13.2 umbrella code. Okay, step 2, we must specify the heart failure. The documentation clearly says chronic systolic heart failure, which, according to our manual, maps to I-50.22. Step 3, we must specify the kidney disease stage. Stage 5 maps cleanly to N18.5. So, your final perfectly compliant sequence is exactly this: I-13.2, followed by I-50.22, followed by N18.5.
By trusting the structured logic of the ICD-10 guidelines, you literally transform what looks like an overwhelming, multi-system disease process into a clear, unified, and totally compliant narrative. It's incredibly satisfying when the pieces just click into place like that. And it really leaves us to wonder, as we look at all the other interconnected systems in the human body, what other hidden clinical connections and presumed linkages are just waiting to be accurately coded in your very next chart. Keep that curiosity alive, keep leveraging your guidelines, and thank you so much for joining me for this explainer.